All right, good afternoon, everyone. Happy to see all of you and see your faces and see your names. I am Rosie McCool with the Chief Probation Officers of California, here for one of our informational workshops. Very excited to have Health Management Associates here with us this afternoon to provide an overview of CalAIM, the Justice-Involved Initiative. You'll see some familiar faces during this presentation. Before we get started, just want to cover a couple housekeeping items. First, if you could keep yourselves on mute, and when you want to speak, please do feel free to raise your hand and then you can unmute yourselves. You can ask questions that way, and certainly you can use the chat function. We will be keeping an eye on that as well. Following the webinar, we will be sending out a copy of the PowerPoint presentation. I know individuals are always very eager to have that information, so that will be sent out later following the webinar. And then in addition, we will be recording this, and so it will be posted online, so you will have the opportunity to view the information. If you have a colleague who wasn't able to join but wants to view it, there will be access on our info workshop webpage, so you will be able to find it there soon after. We'll let everyone know when that has been posted. So with that, I'm excited to introduce our speakers. We have Julie White with us, who is a principal with Health Management Associates, and we also have our retired chief and former president of CPOC, Chief Mark Varela from Ventura County Probation, with us today as well. And so very excited to have the both of you here with us. And with that, I will turn it over to you.
Thank you, Rosie. Thank you for the warm greeting. It's always good to be with this group, particularly on a Friday afternoon. So thank you for those of you who are joining. Just a little bit about my background. I retired from the Ventura County Probation Agency about 1.5 years ago, and I joined HMA as a subcontractor. My time with Ventura County, spent 34 years with the agency, the last 13 of those years as the probation chief. I want to introduce my colleague who's going to be joining us. Julie, would you want to say a little bit about your background before we get started?
Sure. Hey, everybody. My name is Julie White, and I am a social worker by background. I'm a principal at HMA, and I spent 30 years working in the justice system. I've worked in the early on courts and diversion and pretrial services. I've done some work with youth throughout my career, but primarily working in correctional facilities, both adult and youth, and overseeing the provision of comprehensive healthcare services.
Great. Thank you, Julie. So it's great to be with you this afternoon. HMA is a proud probation partner, and we want to take this opportunity to just give you an update regarding CalAIM and the Justice-Involved Initiative. We have one other colleague that's with us today, Kelly Wright. She's going to be controlling the PowerPoint, and she'll also be monitoring the chat. She'll also be, throughout the presentation, dropping very helpful links to documents that could be used for research and reference in case anything that we say today, you need to dive in a little bit deeper into what the regulations have in place. So Kelly, if you can go to the next slide. So this presentation is not designed to be a CalAIM 101. We figured that CalAIM has been on the chief's agenda for quite some time. It's a very lengthy, complex initiative, and we can't cover everything in it in the time that we have today. So we're gonna cover it with pretty broad strokes. And if there's any questions related to anything that we mentioned, then please feel free to drop the question in the chat. So when you talk about CalAIM, Medi-Cal reform, the probation departments are no strangers to reform and transformation. Over the past 2 decades, probation departments have led a lot of the reform efforts as it pertains to the justice system throughout California. CalAIM's a little bit different in that the focus is really on improving the transition for individuals exiting correctional facilities back into the community, and also focus on improving health, physical health and mental health conditions of the individuals that are dealt with by the probation department. So CalAIM isn't designed to change anything that probation departments have put in place over the last couple decades. As a matter of fact, it's designed to preserve the work and to enhance current services that are being provided to individuals who are in our custodial facilities. There are some new requirements, and it will result in new partnerships with managed care plans, new partnerships with other county partners in doing the heavy lift associated with CalAIM. But it does come down to new opportunities for the justice-involved individuals that are currently being served by probation. Next slide. So the agenda today for the workshop is to, again, talk about CalAIM, a very broad overview of what it is, and discussing where probation departments should be with their efforts regarding CalAIM. We're going to talk a little bit about departmental readiness plans, and we realize that many counties are further ahead than others. So we'll talk about where you should be at this point. We'll also discuss substance use disorder requirements and how they tie into your CalAIM readiness plans. Because HMA works with a number of counties already, there are some pitfalls, things that we have heard, and we're going to mention some of those as things to avoid. And we're going to spend some time talking about CalAIM and how CalAIM can assist with reentry planning and opportunities for integration with countywide stakeholder efforts. So these are the things that we are planning to cover in this webinar. And again, if there are any questions that come up as a result, please don't forget to drop those questions in the chat. Now I'm going to hand this presentation over to Julie. She is our subject matter expert when it comes to everything CalAIM. She'll be leading the bulk of the presentation, and I will be jumping in and clarifying some things and maybe asking Julie to address certain other areas that I know are of interest to the probation chiefs here in California. So Julie, I'm going to hand it over to you.
Thanks so much, Chief. I appreciate that warm welcome, and hi, everybody. I just, while Mark was talking, went through the participants list, so some names are very familiar, and some of these slides might look familiar to some of you, but thank you. If you have questions, feel free, again, put them in the chat, raise your hand. We want to make sure that this is a robust dialogue. So I'm going to start off about talking about the Medi-Cal transformation, also known as CalAIM, the overall transformation, and then we'll get right to the JI specific initiative. So there's some basic language I just want to make sure we ground ourselves in. Medicaid versus Medi-Cal. So many of you already know this, but I always run across folks that are a little confused. Medicaid is the federally funded public payer for healthcare. For individuals in this country who do not have access to private healthcare or healthcare through the Veterans Administration, and they could also have it if they have Veterans Healthcare or Medicare, but it is the privately funded healthcare. Medi-Cal is what the state of California refers to as their Medicaid program. Every state has a different name. Washington State refers to it as Apple Health. Massachusetts refers to it as Mass Health. California, it is Medi-Cal. And it is administered by the Department of Health Care Services in California. We're going to talk about waivers because the Medi-Cal transformation, also known as CalAIM, came about through some waivers, and waivers are opportunities for states to petition the federal government and say, we have a hypothesis and we'd like to do a demonstration. We think that there is a different or more progressive or unique way of providing healthcare services that you, the federal government, do not currently reimburse us for. And what they will do is they'll write up an application for this demonstration and propose how they're going to roll this out and what they expect to see. And it's meant to be a 5-year demonstration period. So the federal government loved what California put into their 1115 demonstrations, particularly related to justice involved. It is the model for the rest of the country. Since California got the approval, there's multiple other states who also now have this approval, and many states that are currently pending. I do want to let folks know, I get this question all the time. If it's a 5-year initiative, is it going to go away? So I can't answer with absolute certainty, but what I can tell you is there's a lot of bipartisan attention to this issue and being able to connect people to Medicaid prior to release and providing robust healthcare services to individuals who are incarcerated. There's federal legislation pending that would support this through a bill instead of waivers. And I don't think that this is going to go away anytime soon. So it really does behoove us to put our best efforts into making sure this is successful as we stand this up. Another term you might hear throughout this presentation is fee-for-service versus managed care. These are two different models that California and many states use to administer Medicaid benefits. Managed care involves your local health plans, and every county has different health plans. Fee-for-service means that providers will bill directly to DHCS instead of the managed care plans. For this initiative, the carceral settings, the juvenile probation centers, and the adult jails will be billing Medi-Cal through fee-for-service. The health plans will establish a network of ECM providers who will be providing care in the community. And once somebody is released in the community, they will be billing the health plans directly. And enrollment as a Medi-Cal provider is required to offer these reimbursable services. So many of you who have youth detention centers may have already enrolled as a Medi-Cal provider, or your staff are navigating that and doing that now. If you don't have a youth detention facility, and it's my understanding there's 18 counties that don't, the facility that you send your youth to will have to enroll as a Medi-Cal provider. Next slide. And we're going to give you guys these slides. So if you have any questions, you'll get these afterwards. So this again is a 5-year initiative, and it is broader than just the Justice-Involved initiative. It's really focused on broad delivery system reform and more equity for healthcare services across Californians. It is also looking at payment reform and how can we provide robust services, make sure they're equitable, and make sure that they are being paid for and looked at very carefully so that there's not waste. CalAIM is implemented through the 1115 waiver that I just talked about. It is also implemented by a couple other federal options, the 1915B waiver renewal, state plan amendment, and contractual changes. This is an agreement that DHCS has entered into with CMS, and it's important to know there are elements of this demonstration that CMS is going to hold firm and require the states to carry out. We'll talk about that as we go along. So I do hear sometimes from probation and sheriffs, well, we're going to petition the state to see if we can get a waiver to not have to do this. And what I say to that is, you're probably not going to succeed because this is being monitored by the federal government. Next slide. We already talked about this, but you can see most Californians are enrolled in managed care plans if they receive Medi-Cal. Fee-for-service populations are much smaller, but expected to grow over the next couple of years. So this initiative, the broad CalAIM or Medi-Cal Transformation Initiative, is the largest, most comprehensive changes to California's Medicaid program in its history. And again, the intention is to drive quality care improvements, reduce complexity, and some of you guys are probably shaking your heads right now saying, I don't think that that's happening, but the overall goal at the end of this is to reduce some complexity and build upon equity-focused, data-driven, and whole person care. And by whole person care, California has been really progressive in recognizing that healthcare does not just include behavioral and physical health needs, but really recognizing health-related social needs and how they impact all of our healthcare, whether it be access to transformation, stable housing, access to food, food stability, education, community supports, etc. So there are new services that come along with this, and there are new, it's okay, Kelly, and there's new payment models. Next slide. So what DHCS hopes to accomplish is identifying and manage member risk through whole person care initiatives and addressing social drivers of health. The idea of this overall initiative is to meet the populations of focus, and there's 9 populations of focus where they're at, and put more robust services upstream to prevent more costly care downstream. So as it relates to the JI population, the hope is that providing more robust healthcare services to individuals while they are held in detention and carceral settings, and providing strong linkages to care before they get released, the hope is that it will prevent unnecessary hospitalization and costly care that we often see when folks return to the community. Again, they hope to move to a more seamless system by reducing complexity. Time will tell. And overall, we want to see improvement in quality outcomes and reduction of health disparities for folks. Next slide. So Medi-Cal benefits. Benefits for folks who receive Medi-Cal are set by DHCS. Members can learn more about it in their member handbook. All of the managed care plans are required to provide some core healthcare services, and I'll show you a slide on that in a moment. In addition to the core healthcare services that have to be provided by every health plan, there are services they were formerly known as in lieu of services, but these are now referred to as community supports that health plans can choose to adopt to help support the whole person needs of their members. Medi-Cal beneficiaries receive care at no cost to them. They do not have any co-pays and they don't have any deductibles. Next slide. So this slide, and again, we'll leave it. I'm not going to read it off all to you and put you to sleep on a Friday afternoon, but these are the core services that every health plan in California must provide. And it's very similar to what you'll see in your carceral settings as well. And maybe some things that are extended like LTSS, which is long-term care services and support. But most of us who've worked in correctional settings will see that many of these services are covered in our correctional contracts, whether you provide it in-house or you contract out to a private vendor. So managed care plan requirements. So your partners, the managed care plans, and hopefully many of you have got to talk to your managed care plans. Each one of the managed care plans was required to hire a JI liaison who is tasked with reaching out to the correctional facilities, both the adult, sheriff's departments and probation. And they have to now provide enhanced care management. This is a new benefit. And again, it's a whole person approach. I'm going to date myself a bit, but back in the day, we would call this wraparound services for individuals. And it addresses both, again, these clinical and non-clinical needs. So whole person care and HHAP, those are things that you might have heard in the past. They were pilots that led this initiative. They are now considered to be enhanced care management benefits. Community supports, like I mentioned, are voluntary, flexible wraparound services that are medically appropriate and cost effective. I'm going to show you a list of those in a minute or so. Managed care plans now are required to manage their members through population health management program. And this is a whole system approach to healthcare. It's person-centered, but it also takes a look at high-risk populations and what we can learn from trends and data. And hopefully, learning from the trends and data related to these high-risk populations, we can build more preventative and upstream services, again, to prevent high-cost care downstream. Care plans also have to transition to dual eligible special needs plans, DSNP, and other managed long-term care services and supports. And there's a standard enrollment process now that is consistent with managed care benefits. So this is all, again, part of that overall Medi-Cal transformation. Next slide, please.
Julie, I want to go back and ask a question or get your opinion on the JI liaisons. These are individuals who are designated by the managed care plans as folks that will coordinate with custody pre-release manager or managers, right? So that warm handoff with a youth back into the community is done seamlessly without any hiccups. Now, what do you recommend for probation departments who have not had any contact with the JI liaison from a managed care plan?
I would recommend that you look into who is your health plan and contact them, or if you need help, you can write to me and I can figure out who you need to be connected to. We know a lot of the liaisons at this point. And you make an introductory call and you set up a meeting with these people. They now keep in mind this is a new role and they don't understand corrections. They have a lot to learn from you. They have a tremendous amount to learn about your system and how care is delivered, not only in your youth detention facilities, but the work you do to support probationers in the community as well. So, reach out, do those introductions. Some counties have done a tremendous job of inviting them in and giving them tours of their facilities, letting them know who's part of their multidisciplinary teams. And we're going to talk about that later in the presentation. When you're doing reentry planning, it's great to have either these people at the table or at least have them aware. That's a great question, Rosie, about DHCS. We can check and see. I don't know that I've seen one yet, but we can check and see. And one of the things that we're finding, there's a couple of things I want to caution you about. These are human beings just like you and I. This is complex, nuanced policy. Sometimes they're confused by it. So, if you understand information a bit differently than what they say, you might want to look to DHCS and see if they can clarify, and it's not unusual. The other thing is they were tasked with building a network of justice-involved providers. And for the plans that HMA works with, we've really advised them to work with their local partners, probation and sheriff, to see who's already being used for these warm handoffs and linkages. The last thing we want to see happen is them building up a network of providers that you're never going to use, or for whatever reason, maybe you had a bad experience with in the past. So it's really important that you make these connections early with them to make sure that they're building a network that truly meets your needs.
Thank you, Julie.
Yep. Next slide. So these are the populations of focus for the overall Medi-Cal transformation. And a lot of this, I think you're going to look at, chiefs, and say, well, we deal with all of these, right? So the JI population of focus is primarily, again, focused on services pre-release and making sure that there's linkages. But there are enhanced services now for individuals experiencing homelessness, individuals at risk for acute hospitalization, the SMI population, SUD population, youth services, children and youth. This is your population involved in child welfare, individuals with intellectual disabilities, and pregnant and postpartum individuals. And postpartum in California is defined as 1 year after giving birth. So you can see we're going to focus most of this talk on the JI population of focus as it relates to the pre-release services. But by connecting with the health plans, you may learn about benefits that can help your adult and youth that are in the community and never go into a carceral setting, or they're being monitored in the community. Next slide. Community supports, why it matters. I think I already touched on this, but we know that, people, to be healthy, if you don't have stable housing, we know what goes along with that. You don't have access to telephones, you don't have access to internet regularly, you may not have refrigeration for medications, you may not be able to get to your appointments. There's a whole host of things along with healthy food, respite, and transportation. So the state really recognizes that these are key things that need to be in place for people to get the care that they need and they deserve. Next slide. So on the right-hand side, you can see all the community supports. There's going to be a 15th one added, and I think it's in the process right now of being added. But they include support around housing transition, housing deposits. This is huge. Now in California, some of the healthcare plans will be offering 6 months of transitional rent for individuals. Who better than to take care of that? Or to take advantage of that than folks transitioning from carceral settings. They'll pay for asthma remediation in the home, medically monitored meals and tailored meals, personal care. So, I encourage everybody to be familiar with this. And when you do meet with your health plans, ask directly, what community support services will you be offering to your members? Next slide. So now we're going to get into the JI initiative specifically. And I say this, where should you be loosely? Because I think just by looking at the folks on the call, we have folks that have already submitted the readiness assessment. We have a few counties that have gone live. And then we have some counties that are still working on their implementation plans, and it's okay. Wherever you're at, we're here to provide you information and just want to help see you get to the finish line of this. So this is a slide that one of my colleagues created. The puzzle piece on the bottom, many of you seeing DHCS created that. The top part summarizes what I was just saying about the overall Medi-Cal or CalAIM initiative. We're going to focus now on just one of those 9 populations of focus, and that's youth and adults who are transitioning to the community. And this puzzle piece on the bottom shows all the core elements of what this initiative involves. So many of you are already been in the throes of making sure you're seeing if people come in, if they have Medi-Cal, or you're signing them up for Medi-Cal. Many of you are sending reports into the state, letting them know how many people were screened, how many people were found eligible, how many people denied to accept it. So many of you are already in the throes of this. As you go live, you're going to be able to stand up 90-day services. And many of you are already providing a lot of the services that are already required. There may be some new services, and we'll touch on those that you need to stand up. But the important thing here, and the biggest change that I think comes with this, is the ability to bill for these services. Many of you guys know you either pay a vendor or you do this in-house, and there is a set rate that you have for healthcare services in your budget. And your providers that are working in these environments have not had to bill or submit claims. And in order to do so, there's a lot of infrastructure being built up, including a development of electronic health records, maybe partnering with third-party administrators who can submit claims on your behalf, training of your providers and staff around appropriate documentation, and making sure that your system will be ready to accept the revenue that's coming back directly to the carceral settings. Remember, with this initiative, the providers will be billing DHCS fee for service, but the revenue will come back to your facility. It does not go back to the providers. And so oftentimes we talk about revenue cycle management and how are you going to accept that revenue and work that into your budget. There is also, an element for making sure you have strong behavioral health linkages so that you're partnering with your behavioral health agencies and making sure that people who have both serious and persistent mental illness and mild to moderate are connected to providers prior to release. And this is the same with substance use disorder, making sure you're doing good screenings on these individuals and connecting them to services. Connecting them also to other providers who can provide those enhanced care management tools, take advantage of the community supports, and then working with a network of providers in the community who can continue the care that many of you guys often start for these individuals.
Julie, if I can add something quickly on the readiness assessment. For those counties that are just barely taking a look at that, and for those who haven't yet, DHCS has a template. And I recommend that you take a look at it, read through it. There's a lot of moving parts that need to be put into place in order to complete the readiness assessment. But take a look at it, see which parts that you're going to need to address, and start formulating a timeline of when to have this completed. It's something that's very in-depth, and it will take some time. But if you haven't already dove into it and read the template, I recommend that you do that.
Yeah, and I don't know, Kelly, if you can find the link to it. Sorry to put pressure on you, but if you could find the link and pop it in the chat, that would be great. And if not, I'll do it before the end of this. It's a 55-page document. You have to fill out the whole thing, and not only do you have to fill it out, you have to fill it out for every facility you have. So some of you have multiple facilities. So don't hesitate to get started. Put a project plan in place. Make sure you have a team of people who can help you through it. It is a robust initiative, and it's going to take a lot of work to get this done. And we'll talk about some common pitfalls that we see with this as we go further along in the presentation. So legal authority. I often get questions. I've heard early on comments, I'm not going to do this. You're not going to tell me what to do in my county. This is a legal mandate. The state empowered DHCS to seek this federal authority, and not only seek the federal authority from CMS to make sure that it's carried out. So again, this is a mandate. We haven't seen, an announcement around carrots and sticks related to this. And I think as corrections professionals, sometimes that's what we respond to better. But what I am seeing in counties is the Board of Supervisors are looking at this. They're expecting there to be a cost offset to the services that you're providing. And I think if some of you have not been called before the Board of Supervisors yet, it will probably happen, because they're going to start asking questions about your budget, right? And does it need to remain level funded to where it's at for healthcare services, or can there be a reduction? And we can talk about navigating those conversations. So I think when we talk about the stick, that's going to be the stick, is that the state is expecting there to be some offset of services. And the only way you're going to get that offset is by submitting clean claims and capturing that revenue coming back. We'll talk a little bit more about that as we go on.
Julie, I want to add something about communicating with the Board of Supervisors. If you have a budget analyst or a particular supervisor that's really eager to make sure that you are billing and receiving money to alleviate some of the pressure on the general fund, it's also a really good opportunity to ask and let them know what your needs are as well. This is a heavy lift, and it shouldn't rely solely on the shoulders of probation departments. You should be engaging your county partners. And if you have a county partner who is not at the table or not being of some assistance, then in your correspondence with the Board of Supervisors, it would be great to bring that up, because it's going to take a team to do this. And just make sure that you include those needs that you have as a department to complete this readiness assessment, and make sure that all the county partners are at the table helping.
Kim, I just saw your question. We have some slides. They're a little further along in the presentation that will spell out exactly what the requirements are if you don't have detention facility. And I'll answer it real quickly, and we'll get into more detail. You do need to partner with the county that holds your youth and help complete that readiness assessment. Kelly, thank you so much for putting that up. Next slide. Kelly put in the chat the readiness assessment for those of you who haven't seen it or downloaded it yet. So the state mandated facilities who have to carry out this initiative, your jails, your county adult jails, sheriff's departments, the CDCR, obviously, and the county youth detention facilities. And again, if you don't hold youth in your county, then the expectation is that you are partnering with the county who holds your youth. So I know Tehama, I think they receive folks from about 5 different counties. The expectation is that the sending counties will partner with Tehama on their readiness assessment. Next slide. So the Justice-Involved Initiative goals, I'm going to go through this quickly, just in the interest of time. Again, similar to the overall CalAIM initiative, advance health equity, improve outcomes, and again, really serving as a model for the rest of the country. And I will tell you, I am on calls every single day from all over the country with people asking me, how are they doing this in California? I get calls from New Hampshire, Minnesota, North Carolina, Washington State. I just got one from Ohio today. Every single day, people are asking, what are they doing in California? So the good news is some of you can retire maybe and do what Mark's doing and talk about lessons learned down the road, because there's going to be plenty of opportunity. But you guys are blazing a trail, and I know it's frustrating. I think all of us shake our heads at times because you are, blazing a new frontier, and there's not always solid answers. But just encourage you guys to hang in there, because you're doing something really progressive and really with the intention of providing the best outcomes for the people that you serve. Next slide. We already went through this, so I'm just going to skip through this again. But the covered services, so when we talked about that puzzle piece that talked about pre-release services, this is what California told CMS that they will provide. So care management services for both physical and behavioral health, clinical consultation services that can be provided via telehealth or in person to diagnose health conditions prior to somebody being released, provide treatment prior to release, and also help develop pre-release plans and linkages to care in the community. Lab and radiology services will be covered. Medications and medication administration are covered. There's a specific call out for MAT, and I want to come back to that. They will also reimburse for services provided by community health workers, and oftentimes these are individuals with lived experience that may serve as peers or navigators. And it will also cover outpatient prescribed medication and over-the-counter drugs, as well as durable medical equipment. These things will all be covered and reimbursable for Medi-Cal eligible folks in your institutions 90 days prior to release. So many of you are probably saying, well, Julie, I don't even have people for 90 days. And we'll talk about what the short-term model requirements are in a minute. But the intention here is that you're able to pay for as many of these services through claiming and reimbursement 90 days prior to release. And if you're able to get real efficient, and some of you guys know what I'm talking about with this JI portal and making sure people are signed up, doing all of this front loading at booking, ideally, you could have the bulk of their healthcare services paid for. Even if they're not going to stay with you for 90 days. It does get tricky, and we can talk about that. Next slide. Behavioral health links. So this is really important. If you haven't connected with your behavioral health agencies to do so, they are responsible for receiving all referrals for serious and persistent mental illness and SUD. And the state is saying that they really want the correctional facilities to develop appropriate screening tools in conjunction with their behavioral health agencies. So many of you guys are already doing these screenings with the youth when they come in the adult system. There's multiple screenings, whether it's the Maisie, the CANS, the Texas Christian University screening tool. You guys are doing these screenings, but the idea here is to make sure you're working with behavioral health to make sure that they agree with these screenings and will agree with the assessments and the referrals. You really want to be working with them to initiate these warm handoffs prior to release. And when we talk about warm handoffs, you guys all know this, the best practice is to do these introductions to somebody who they're going to be working with in the community prior to release. I think those of us who started doing reentry back in the 90s thought, okay, this is great, we're going to refer them to an appointment. And then we were really dismayed to see nobody was showing up to these appointments. And so we've learned a lot in the past 30 years, and we know transportation is a big issue, and we know it helps to make these connections prior to release so people feel comfortable knowing who they're going to be meeting with.
So Julie, I want to reemphasize that particular piece. You said behavioral health services, they're mandated to provide these services to the justice-involved population, correct?
Coming out of the carceral settings. Yeah.
Okay, and they have worked with DHCS on separate plans on how they are going to be
Yes.
providing these services. And it's important for that to be communicated to probation departments who are operating juvenile detention facilities.
Yes, and in fact, when you are ready to submit your readiness assessment, you also should be submitting a letter from your behavioral health agency saying we support the tools that they will be using for screening and assessment. So it's really important not only that they're reaching out to you and letting you know what they're going to be capable of providing, and we know many behavioral health agencies subcontract out services, so they might just be the filter to a vendor in the community. But it's important for you to know what they have lined up, and it's important for you to check with them and really get their buy-in. And I know that can be challenging sometimes in some counties with different county agencies, but the earlier you can have that type of collaboration discussion, the better off. There's been, oh, Rosie?
Yeah, I just wanted to follow up on that. So for a probation department where they contract for services and it's not county behavioral health, but the probation department is directly contracting with, regardless, the county behavioral health is required to provide this service and collaborate with probation. Could an option also be for county behavioral health to contract with whomever probation has been contracting with to fulfill this requirement? Hopefully that makes sense.
Yeah, it does make sense. And I can see some of the folks that I work with are on this call, and they're probably their ears are ringing because they have this exact problem. They have multiple contracts with community-based providers. It doesn't go through BHS. They have good relationships with, and I'm not here to say you can't continue that, but what I am cognizant of politically and financially is I do think there will be question if you can capture revenue, right, for doing this with the behavioral health agency, and the behavioral health agency can build Medi-Cal, and they're getting that federal matching funds, right, from the feds for this. I do think that the time will come where probation departments, when they're looking at their budgets, there's going to be questions about if this service is mandated to be provided through BHS, why are we paying for these other contracts? So there will probably need to be some amendments to contracts. And if you're working with partner agencies that aren't subcontracted through BHS, you may want to start having those conversations with them to let them know who you're currently using. Does that answer your question, Rosie?
I think so, but I guess part of my question is, can the county behavioral health department, so you capture that savings, contract with whomever probation has already been working with? Can the contract flow through behavioral health so you still capture the savings?
Yeah, unfortunately, that's a county and an agency specific decision, but
it is possible.
It's definitely possible. Okay. It's a matter of, are they willing to do it, and what kind of politics and contracting things do you have going on in your county? But it's a great point. And if you are working with folks that have been just really great, I really say get in front of BHS and say, we would love for you to pick up this contract. So this slide shows, this came out of one of the counties that we're working with, and they said, I just want a clear understanding of what's our role and responsibility versus behavioral health's role and responsibility. So the correctional facilities, you guys got to do the screening and assessments. You got to get the consents to treat and share information. And I don't want to say that lightly, that's a big task, right? And you want to provide the services, including MAT, prior to release. Behavioral health also has to get consents. They have to agree to data sharing. They have to do reentry planning with you guys, and they have to be available for this professional to professional handoff. In the community, they have to provide the care or contract with somebody who can provide the care. The managed care plans are expected to manage individuals with mild or moderate BH issues. There are some county behavioral health agencies we have seen who have said they want all referrals going through them. But what the state is requiring is that all severe and persistent mental illness and SUD goes through behavioral health. And it's up to your county and how well you guys work together to decide if you're going to refer everybody or just those populations.
Julie, we do have some counties that have gone live as of October 1st. So those behavioral health links have to be in place as of October 1st.
Yeah.
They have to be ready to receive referrals from the correctional facilities. It's probably a little too early to see how it's going, but maybe in a couple months we could learn from the experiences of these counties who have gone first and how that piece is working. Because I can tell you from a probation perspective, establishing those links prior to release is so important, and it requires a lot of coordination and communication. But probation departments can only do so much. The entities out in the community have to be established and ready to take these referrals, because we know this population, if a person's idle for 2 to 3 weeks before they can get in to be seen and for services to start, is a very crucial and important period, and that gap needs to be completely closed.
Thanks, Mark. Yeah, that caused some confusion because all behavioral health agencies in every county were expected to be able to receive referrals October 1st, even if their local sheriff or probation was not ready to go live. And we have heard from BH agencies that they have been getting referrals from different counties. The CDCR is not ready to go live yet, but we're thinking by the end of the year, it sounds like, or early next year, they will be. So they are starting to receive some referrals, but I've also heard of some counties getting phone calls from their behavioral health agency, like, why didn't you send anybody to us? And they not everybody understands you guys don't have to go live October 1st, so you didn't have to, obviously. They had to, so they may not see, you know, the referrals that they were expecting from your county right away. Next slide. All right, so short-term model. I included some slides. They're right from DHCS, and in the interest of time, I'm going to talk really quickly about this. But the state recognizes a couple things. This was built with prisons in mind, and California is not unique in this manner. I talk with states, like I said, all the time. They really needed to get buy-in from the chiefs like you and the sheriffs when they design this. And, you know, more often than not, that just doesn't happen. So they recognize you do not have people serving long sentences or sentences with set release dates. You have people churning in and out of the facilities, right? And many have average lengths of stays that are less than 30 days. So the state recognizes this and has put some recommendations and guidance in place of what they would like to see happen in a short-term model. These are just recommendations. They are not mandates. And I think that takes a lot of pressure and stress off of some folks, particularly our jail and probation partners who are thinking, I cannot do all of this with people who are coming in and out of my system in 24 hours, 48 hours, 72 hours. So the model, I'm going to show you in the next couple of slides what they're recommending, but keep in mind, they realize you may not be able to do a lot for these short time folks. Next slide. All timelines are associated with the first 7 days of the JI code activation, right? So what does that mean? You have to make sure somebody is either on Medi-Cal when they come in, and then you can put that information in and activate their JI code right away. And we recommend that you do that and keep that active unless you learn from the court that somebody's going to be with you longer. For those who need to be signed up, we do know there can be some delays if you're not using an electronic system and getting them signed up on Medi-Cal. Hopefully counties are moving towards electronic systems that are more timely, and you can get that number much more quickly and activate that JI code. But there's certain services that are expected to be provided according to the CalAIM mandate within the first 7 days of that JI code being activated. Many of these things you guys are already doing right when people come in the door or within the first couple of weeks anyways. So I don't see the services being a different lift. The management of the JI portal, though, is a different thing. The next two slides, I'm just going to flash them up. But again, we'll give you these. They come right from DHCS. I got, give them credit, and their consultants gives suggestions around what services should be provided on the first 7 days of incarceration. What I will call out is the SUD and MAT requirements. CMS was very clear that in order to grant this to the states, they had to provide MAT prior to release. This is non-negotiable with CMS. They want to see, and California wants to see, you are screening people as soon as they come in, assessing their needs for MAT. And we know a lot of juvenile facilities may be doing this already or have the opportunity to grow in this area. And that if somebody is appropriate for medication-assisted treatment, that they're getting started on that as soon as possible. We know that these medications are life-saving. We know they block your opioid receptors. We know that reentry is a high risk of death from overdose. And so the state and the feds really want to see capturing these folks as early as you can and getting them started on this medication. So those are the things I would pay a lot of attention to right away, is if you have the opportunity, you're screening them, you think they're an appropriate candidate, or your clinicians think they're an appropriate candidate for MAT, to get them started on that. Next slide. I'm going to send this out. It's a lot to look into, but again, it's a proposed model of care for individuals who will be with you for short term. Next slide. So what are you working on right now? So my guess is many of you are really starting to work on Medi-Cal eligibility screening and application support, or some of you might be saying, well, Julie, we've been doing that for a year or so. And what I'll say here is, is it optimized? Are you getting as many people signed up as you can? Because we know the vast majority of people in these settings will be eligible. And we also know if you're asking them when they come in the door and they're going through withdrawal, or they're acute, have an acute mental illness, or they don't feel well physically, they may say, I don't need this, I don't want it. Many of the facilities we work with now are saying you're asking 3 times. Right? So it's not just during booking that you're doing this, you're going back and you're really doing some motivational interviewing around, this is a benefit to you. And the reason I want to stress this, if nothing else, if you walk away with nothing else today, I want you to keep in mind, you cannot capture the revenue for the services you're about to stand up if you can't submit the claims. And you can't submit the claims if they're not signed up for Medi-Cal. So this is a crucial step that cannot be underscored. If you are seeing low numbers of people signing up, I encourage you to get together with your team and think of what you can do to optimize this and get more people signed up in a timely manner. My fear is that if you just say, oh, they don't want it, you're going to stand up this infrastructure that's expensive, that many of you have Path 3 funding to do right now. But when those funds dry up, you need that Medi-Cal claim reimbursement to continue to provide this level of service. So I strongly encourage you guys to take a look at those numbers. You're probably working on building up or seeing what services you already offer, making sure they align with the pre-release services and seeing what you have to build. And for the youth, I do think a lot of facilities are really starting to look at how do we stand up more robust MAT programming. If they turn 18 while in custody, I'm going to take that question down, Mariah, and get back to you. I don't think they do, but I'm going to just double check with DHCS for you. You should be, again, if you haven't connected with your behavioral health agency, you should be doing that. Working with your partners in your health plans on the warm handoffs. This is another thing. Do not delay. You got to submit claims. And the best way to do that is through enhanced electronic health records. So take advantage of the Path 3 funds. A lot of you are doing this. You're building out different modules for EHRs, or you're getting different EHRs. If you're still on paper, take advantage of these funds to get an EHR. It is going to save so much time with billing, and there's plenty of community based EHRs that have been doing this billing for a long time. Correctional vendors are starting to catch on. This is the wave of the future. They're building out modules. Make sure you are doing this, because we know any change in EHR, if you're lucky, it takes 2 years, right? If you're lucky. And the vendors will say, oh, we can do it in 6 months. We can do it in a year. Ignore that. Just ignore that altogether. It's not going to happen in 6 months. So make sure you're getting on that. Make sure you're enrolling to become an exempt from licensure medical clinic through the PAVE system, that you're starting to talk about how you're going to submit claims and who's going to do that for you, and who's going to do some internal audits to make sure that they are accurate and clean, right? The last thing that we want to see, you guys are now taking on responsibility for fraud, waste, and abuse. You want to make sure your providers are submitting clean claims. So think about, how do you audit that? And then the other big lift that we see is data sharing agreements. You've got to share data, and everybody likes to receive data. Nobody wants to share data. You got to share data with your BH agencies, your MCPs, right? Your social service agencies. And so if you haven't started working on those agreements, I strongly encourage you to do that as soon as possible. Next slide. I'm going to just go through the readiness plan. Kelly already put the link in. This is just a timeline of where you've been and where you're going. So many of you guys are doing the work to develop the readiness assessment. Congratulations to those of you who already submitted, and of course to the 3 counties that went live. You will have to have the assessment submitted to DHCS 6 months prior to your go live date. And they will review it for those 6 months. And if you get approved, then you'll be able to go live with that. The latest that you can go live is September 30th. September 30th of 2026. And we know there's no harm in waiting. When I talk to people about their readiness assessments, it's one thing to fill in the 55-page document and attest to things and write down what you think the process is going to be. It's a whole nother thing to operationalize it and make sure it's embedded in your policies and procedures, and that you've made updates to any contracts or MOUs that could be impacted by this. I see a question. Do we have to audit ECM bill? Nope. You don't have to worry about the ECM billing. That goes through the community-based providers. They will take care of that through the health plans. But if you have a vendor or your docs are submitting claims, you may want to consider having somebody, whether it is county personnel or a third-party administrator, doing some audits to make sure. And I say this especially with the folks that have vendors, because the money's not going. So if you have like WellPath or NAFCare, it's nothing against them, but the money's not going back to them. So their stake in this is not as heavy as yours. You guys are going to be the ones receiving the money back or not receiving it. So you may want to do some double checking and some audits to make sure they're submitting things accurately. Next slide.
Julie, I want to go back to the comments you made about the counties. So we know that there are 40 counties that operate juvenile detention facilities. There are 18 counties that do not, and contract with a nearby larger county to have their kids housed there. So the correctional facility, or the prime county, is the entity that's responsible for putting together the readiness plan. You made the comment earlier that the partnering counties should participate in the readiness planning, because it's really hard for a county, you mentioned Tehama, to know and be familiar with all of the linkages in other counties. So it's so important for the partnering counties to participate in that process and to make sure that those linkages are established, and to ensure that the youth coming back to their counties of jurisdiction are enrolled and receiving services back home. Does that make sense?
Yeah, definitely. It's the state is saying that the county sending have to be part of the readiness planning. And I think that's kind of lost in the fine print. Um, and you know, if you haven't made those connections yet, I think it's important that you start reaching out to those partners so they can help inform that plan. I fast forward it because these are always such good conversations and never enough time. So there are slides that we passed over about the MAT requirements. And I do want you guys to be able to take a look at them. I really stress they want you to start people on MAT as soon as possible. All forms of FDA approved medication, you know, you are expected to provide at least buprenorphine or methadone. You're encouraged to provide both, whatever is clinically appropriate. And if you guys have more specific questions about the MAT requirements, we're going to send an email address up at the end of this where you can ask us, and we'll get back to you about those requirements. And again, we'll give you those slides. But I think for this point in the conversation, in order to leave room for more questions, I want to talk about some common pitfalls that we're seeing, and then I want to talk about a little bit about that reentry planning, what to expect with the adults, and if you don't have a youth detention center. So next slide. Okay, so common pitfalls, delaying getting started. You guys, you deal with so much different propositions. Every time I get on a call, acronyms, propositions, I don't know, you know, what's going on. You guys take on so much, and I understand why it's challenging to get started. But I strongly encourage, if you guys have not started on this planning, to do so, and do so right away. It is a lot of work, and it can't just fall to one person. I see so many counties, and it's because you don't have a lot of resources, and I get it, where this is falling to building lieutenants to carry out, and it may be the only resources you have. But if you get a team together and you start looking at this, I strongly encourage that you start doing it now. It's a lot of work because, like I said, it's one thing to fill out the assessment. It's a whole nother thing to operationalize it and make sure everybody knows their role and how it impacts their job. And it will impact a lot of people's jobs and what they do from day to day. Think about your team composition of who's working on this with you. It's important to have custody and operations at the table because nobody moves in corrections without custody and operations. It's also helpful to have, you know, somebody who's familiar with the delivery of healthcare services, maybe a contract administrator or a health service administrator at the table doing this planning, a behavioral health clinician that may work with your facility. Also having human resources at the table. Some people's jobs may change, and you don't want to get caught up and not understanding that. And there are some new jobs that may need to be created. So at least bringing them into the conversation, your legal counsel into the conversation, your finance people into the conversation, and of course your IT people. That's really important to have these key players at the table. And I know some of you are smaller facilities and you don't have all of these. But I strongly encourage you to really spread the love. What I see happening is so many people leaving it to one person in their institution to take this on. They will burn out. You know, we've seen it. And it's not something that one person can handle. I already talked about data sharing agreements. Again, if you haven't started on getting those, and you have questions about what types of data sharing agreements, you can email me. We'll put that email up at the end. Your health services contract, if you have a contract with a vendor, it's going to change. So even if you're keeping the same vendor, you're going to have to do amendments to the contract, because we all know that if you have a vendor and you start telling them they have to do something different than what they bid on, what are they going to say? We didn't bid on this. We're not doing it, or it's going to cost you more money. You gotta have those conversations now. If you're putting it out to bid, you need to include the requirements of CalAIM in your new RFP. And if you're not putting it out to bid, you got to amend it, and you got to get in front of your vendor sooner rather than later to let them know you're going to be amending the contract and there's going to be some expectations. Same with any other memorandums of understanding. Some of you might be working with community partners that you're going to expect to provide care management. Those contracts will have to be amendment. Pharmacy contracts will have to be amendment. Keep in mind, the pharmacies, if they are licensed in California, they will be billing Medi-Cal directly themselves. They will get the reimbursement. We don't want them double dipping. So you don't want to keep paying them, you know, these same rates that you keep paying them for medications that in large may be covered through Medi-Cal. So look at those agreements. Policies and procedures, so many policies and procedures are going to need to be adjusted. So when you're going through that readiness assessment in each of those items, we strongly encourage you guys not only to fill that out, but think about, is this going to affect our booking policy? Is this going to affect our medical policies? Is this going to affect our behavioral health policies? And starting to write down what needs to be amended and going through that process. And we know that that can be hard. There may be new policies that you have to create, and that's even more of a nightmare for you guys, right? But you're going to have to amend policies and procedures. I already talked about an EHR. You really need to get started on that, the billing piece. And again, to just state, communicating early and often with your leadership, your county leadership, your board of supervisors about what you're doing, what funds you got from PATH to stand up the infrastructure, and what you think, you know, the costs are going to be moving forward. Next slide. So the two buckets of state funding currently are, you know, you guys got money from PATH, many of you, not everybody, but got money. You have to stand up the requirements regardless. So hopefully you took advantage of the PATH 3 funding to stand up the infrastructure requirements. What I would say is that if there are any of you on this call that have not submitted implementation plans yet, reach out to DHCS, let them know you want to. They will give you the extension. We know they were due in the spring, but we've seen this. They will give you an extension. They set aside the funds for you already. Take advantage of that. If you need help with that implementation plan, you know, shoot me an email after this, but take advantage of those funds. That is money that is waiting to come to you, and that is what's going to help stand up that infrastructure. And after you go through those grant funds, right, and you spend those down, then you got to be relying on the claims reimbursement to continue that infrastructure. So it's so important that you are making sure people are signed up for Medicaid and that your providers are really understanding what they need to do to submit clean claims. Next slide. This is a slide we created. It's probably not to scale, but it's just to give you a general picture. Many of you are already providing in the blue circle current healthcare services. And I would say this circle is probably small. A lot of you guys are providing robust healthcare services. CalAIM may be asking you to do more, which is in the yellow, right? So we know you currently have, you know, a budget to provide the services that you're providing. Hopefully you do. We know sometimes it's not enough. The orange represents grant funding through PATH 3 that's going to stand up the infrastructure. And then, like we said, that's going to start to go away. What are you going to be able to support this infrastructure with moving forward? That's going to be the claims and the reimbursement that comes from that. Next slide. Okay, so how can it assist with reentry planning? These are the last couple of slides. So the best practice for reentry planning, and a lot of the youth facilities do this, is to have a multidisciplinary team meeting, right? To get key stakeholders around the table with youth and their parents or guardians to determine, you know, what they're going to be connected to and doing when they get in the community. If it's not a current practice, we encourage you to start looking at that. Some of the sheriff's departments also do that. And so if you are providing adult probation services, some facilities have probation embedded already in them. Others, you may have a relationship. We encourage you to come to the table for those reentry meetings if your county is having them, the sheriff department's having them. If they're not having them, ask them if they're open to having something like that, because it really makes a difference when you have everybody around the table and you know where they're getting referred for behavioral health, where they're getting referred for medical appointments, social services, etc. You don't want to be duplicating services if there's connections already being made. You're going to have to develop a reentry checklist. And that's something that is going to be used to talk about all the services that you're connecting people to when they leave. So if you haven't done that already, you don't have one, it might be the time to start developing it or enhancing it to make sure it includes the CalAIM requirements. Care management models. Who's going to be providing the care management pre-release? Is that folks that are going to be embedded in your facility, or will that be partners from the community? Something you need to start looking at. Another big thing, and I hear this all the time, medications upon release. The state is requiring, not only is the state requiring, the feds, this is one of those minimum requirements, feds, 30 days of medication in hand upon release. That doesn't mean a 30-day prescription called in. It doesn't mean what's left in their bingo card. It is 30 days of patient-specific medications in hand. So you need to talk to your pharmacy provider to see how they are going to provide that. In California, we have seen CVS step up. They've partnered with Omni Delivery, and they're promising that if you call in a script, they will deliver it to your facility within 4 hours. So for those folks that are coming and going to court, you might want to partner with somebody like CVS to get those meds in hand. If you're a small county, some counties we know they can drive right over to a pharmacy and get it. BH links, again, connecting with your BH agency and understanding who the ECM providers are. And the best way you're going to do that is to talk to your health plans, ask to meet them. And another best practice that we've seen is to offer them a tour. Offer a day where the health plans and the ECM providers can come into your facility. Put them through the background checks that you require. Let them see the challenges. Movement is not free in correctional facilities. It could take time for their providers to get cleared if they're going in. It's important for them to realize that the world revolves around custody, and it revolves around count times. They need to understand that. So one of the things that we see is invite them in, give them a tour, and also let them see what it's like trying to get into the facility and navigate that. It's really important. Next slide. Okay, so this is language we took right out of the operational guidance. So the roles of counties that do not house youth. Basically, in summary, it says DHCS is requiring that you submit a joint readiness assessment, right? So for those of you guys have already asked really good questions, if you are sending them to a different facility, reach out to your contact there, let them know. You're required to help develop this readiness assessment tool. The prime county will submit it. They're also the ones who will be submitting the claims and getting the reimbursement. But I don't know what your agreements are for healthcare costs with these counties. So that's something that you may want to talk about too. Is there going to be a change in your contractual obligations or how you're paying for services? That's something you probably want to inquire about. Next slide. This is just reiterating that partner counties who will provide a component of pre-release services will be required to be able to demonstrate what their capabilities are. And partner counties should also let DHCS know that they will contribute to the readiness assessment. So the counties submitting the readiness assessment need to let DHCS know when they plan to submit. You don't have to do that today. Many places have done that. Some of you might say you want to, hold off and wait a couple months to see where you are. But when you're doing that, notify your partner counties so that they can reach out and say, yes, we plan to contribute to this as well. Next slide. I think this is a little bit more reiterating what I just said, but let's see here. Kelly, if we go to the next slide. So stakeholder engagement, we've talked about this, understanding your county's responsibilities, whether or not you have a facility or not. If you are embedded in the adult facilities, understanding what their approach is going to be. If you're not embedded, understanding, who they can connect with about reentry plans. Again, getting the health plans, getting to know who your health plans are, who those JI liaisons are, and again, the behavioral health agencies. So there's a lot of information. I did want to leave room for questions. There are slides that we did not go through, and those really talk about the readiness assessment and again those SUD and MET requirements. So you will get these at the end and be able to look through that for more information, and you can always reach out to us to clarify points. So at this point, I do want to open it up. Thank you for being such an attentive audience. And okay, it doesn't look like we lost too many people. That's good for a Friday. So I appreciate your patience, and please let us know what your questions are.
Yeah, thank you, Julie and Chief Varela. A lot of great information and captured in a very succinct way. And so really appreciate the information that you've put together and shared with us. We do have a few minutes. If anyone has any questions, you can feel free to drop them in the chat, or you can, use the raise your hand function if you'd rather just unmute and ask your question that way. And we do have a question. The question is, does the go live date mean when the county can start billing for services?
Yeah, so the go live date means you're ready to stand up those pre-release services and you are ready to submit claims. Now, I will say some of the our early adopters have gone live. They may not have everything in place yet for submitting claims, and some of that was on the state. The JI portal just went live, and so that's a big piece of it. But the expectation is when you go live, you can stand up those pre-release services and you're ready to submit claims fee for service to the state. Great question, Rick. Will we get a link?
Yes, we are going to post the link. It probably will be sometime next week, but we will make sure to send it out to everyone. And then there's what you said at the 64-minute mark, impacts to all our various staff was important. Okay.
Yeah. So one of the things that we've seen successful is for counties that have contracted with us to provide technical assistance, and whether you contract with a consultant to do that or not, to get your key stakeholders around the table and run through these requirements with them. It's pretty enlightening. And oftentimes what we see again is there's one or two people in the department carrying this load. People will say, I heard you kept talking about it. It's really worthwhile to schedule an hour and a half with your command staff and key partners. Like if you have booking officers, medical deputies, it's really important to get these folks around the table and let them know what's coming their way.
Hey, Kelly, would you please put up the ways that folks can contact us if they have any general questions related to anything that we discussed today? And I just wanted to point people to the website Addiction Free California. It has a lot of great information, particularly related to substance use disorder and medication assisted treatment.
Thanks, Mark. And just to clarify, so there's a couple email addresses. So if you have questions specific to your MAT program or substance use disorder, use that top email, right? We still have a contract with DHCS to provide technical assistance to the counties around that. And if your questions are specific to a Medi-Cal, reach out to me. I'll do my best to answer those questions. Anything, and I'll probably be helping to answer the SUD requirements on the back end with the first email. But if there are more questions about your JI portal or training or things like that, use my email address.
And this is part of the slide deck as well, right? So when we send out the slide deck, they'll have the contact information there as well. So that will be helpful.
Yeah.
All right. I'll pause one last time in case there are any other questions that come to mind. But again, we will send out the PowerPoint and a link to this workshop. And Karen, I will for our thoughts. Yeah.
First of all, thank you very much. This is very informational, and I think going to be providing a great resource for folks as they're in just going through this journey. But one question that I had for you, and not really sure yet how this may or may not apply, but are you seeing in any of the work that you may be doing with the counties or any of the discussion you may be having with the state, folks looking at how to operationalize some of this work with pretrial?
There is at least one county that is looking at this with pretrial. And one that I know of, it doesn't mean this is the whole universe, that's also talking to the public defender's office. And interestingly, I will also add, I got a call from a district attorney today too, asking for help about this. So I think that they are, if you have pretrial services in your county, they are a key stakeholder, especially with those folks that are the high turnover getting out and everything. So certainly encourage you to bring those folks to the table. And there are at least one county that I know of that if pretrial is providing any clinical services, they're exploring if they should become ECM providers.
That's helpful. Well, since most of the counties, well, we all offer pretrial services and a majority of those go through probation, I definitely want to be sure that we are kind of thinking through some of those pieces as well. So helpful to hear what you're kind of hearing and seeing out there. So this has been great. Thank you.
Thanks, Karen.
Yeah, and one very important question for clarification that was in the chat before we conclude was about the round 3 funding and whether it's available to those without facilities. And I think before we leave, want everyone to know that all counties can apply for the Path 3 funding, whether or not you have a facility. So it is not limited to just those with facilities. So, and Rick, we can reach out to you after this to talk through that a little bit. And then certainly there's the resources on the page as well. So. All right. Well, with that, thank you both, and Kelly too, for the wonderful job managing the slides, and Amy as well. I really do appreciate the time today spent with us to walk through all of this. Really, really informative. So I'm sure you will be hearing from some folks and continue to partner with you all. So appreciate your time and wish you all a great afternoon.
Great. Thank you.
Thank you.
Thank you.